Okay, so we're gonna talk this. We're recording this in order to help the other people who may want to join us and participate in this project. So just the background is that this is something that I'm passionate about. It's kind of a weird circumstances. I've been working on this, and just a week ago, Bezad Pavri called me and he said, "Hey, I want to discuss with you about a potential quality project," which is something that I've been working on anyway, getting off the ground. And this is the case, just to summarize the big picture for everybody, that everybody is going to be on the same page. We know that we have patients with atrial fibrillation. Either, I'm not talking about those permanent who's been in atrial fibrillation for decades, talking about paroxysmal or persistent atrial fibrillation, who needs to go for cardiac surgery, whatever surgery it is, either CABG or valve surgery, whatever it is, any heart surgery. The guidelines suggest that if you have an indication, if you have atrial fibrillation pre-existing, paroxysmal or persistent, then you need two things. One, ligation of the left atrial appendage, which is kind of like a Watchman device, but that's for every patient with Afib, even if it's permanent. And the second one, if you have persistent or paroxysmal atrial fibrillation and you think that you can achieve sinus and keep the patient in sinus, then you can do what is called ablation, atrial fibrillation or atrial flutter ablation. And the ablation can be done, usually it's an EP procedure that is done in the EP lab. But if you're already exposing the heart, you could certainly do an electrical ablation. And there's different methods to do this. I'm not a surgeon, I'm not EP, so I can't tell you the details, but the common method that is considered more, the more desirable for surgeons with the highest success rate is something that is called the box. And it's basically, without getting into technical issues, what we have observed at Jefferson is two things. And this is what this quality improvement project is to basically meant to do in order to assess the problem, the magnitude of the problem. One is the patient, again, the guidelines suggest to do this, strongly suggest to do this. If you go to surgery, to heart surgery, and you have a diagnosis of pre-existing diagnosis of paroxysmal or persistent AFib, is to go ahead and do the ablation. It's in the guidelines. So we have two problems. A is that often it's not. The surgeons go, they do the CABG, they do the mitral valve, whatever it is, and they don't do the ablation for different reasons. And again, I'm not a surgeon. I can't comment individually. It may be somebody really sick that they want to just close up as soon as possible. But as a system, we, as a leading system, academic hospital, we're expecting to do as much as possible, according to the guidelines, to do an ablation. So the first problem that we have observed, anecdotally, is that we're not doing enough of these surgical ablation. I'm not talking about EP lab, I'm talking about the CT surgery at the time of the heart surgery. The second problem is that even if the surgeons do the ablation for the atrial fibrillation or atrial flutter, often, again, without going into details, it's just basically a few electrical lines, and Bezad Pavri witnesses himself in the OR when he participated in several, which is, maybe good, maybe it's better than nothing, but almost always these cases, it's not like the detailed way to do this. And often these patients post-operatively or in the future, they present back in atrial fibrillation. This is an art, but it's not something that is so, again, I'm not a surgeon, so it sounds like I'm, dismissing the surgeons. But if you know the technique and you learn it, it's not so complicated. There are surgeons who are traveling around the world, cardiothoracic surgeons, who are giving grand rounds education on how to do this, when to do this, and how to do it correctly. So that is kind of like the brief issue. And as we outlined in the problem, many patients who go under cardiac surgery, they face the pre-existing diagnosis of AFib, paroxysmal persistent. Oh, crap. Hold on 1 second. There's a code red alert. I'm just closing the door. So current guidelines, society recommendations advise performing the surgical ablation during the same operation, ideally using an effective strategy such as the box method. And the question is, it's unclear how consistently this recommendation is followed at our institution. Our aim is to evaluate the current utilization of surgical ablation at Jefferson for AFib or flutter who undergo cardiac surgery, to understand the variation in practice, identify opportunities to improve adherence. And, just again, backing a little bit, this has been supported. I've met with my chair of cardiology about this, the chair of CT surgery, Dr. Bavaria, Dr. Frisch, who's the director of electrophysiology. There is huge buy-in. Without a doubt, there's a huge buy-in, and this is kind of like, let's learn what we have, what we're doing, and maybe we can improve. So the methods that we wrote is identify all the surgeries, let's say 2025, whatever, 2024, or we can choose 1 or 2 years. And then the inclusion criteria are those that had any diagnosis of AFib, like paroxysmal persistent fib, flutter, before the surgery. For each patient, we need to recognize, and it's pretty easy to do, if they had a surgical ablation or not, because that addresses problem number A, or the first problem, which is maybe they didn't have one. For patients who did go ablation, it's important to document what did they do? Like, was it the line thing, a box, what approach? And see, and that was kind of Pavri's point, see if there's any recurrence of atrial arrhythmias post-operatively, because usually, just for those who have not rotated in cardiology and CT surgery, often Amin and I are seeing patients post-operatively. Usually after a heart surgery, they stay in the hospital, whatever, 5 days, 7 days, and then they go home. Often, because of the inflammation of the surgery, that's when they flip into atrial arrhythmias. So assess recurrence of atrial arrhythmias post-op during the index hospitalization, meaning the hospitalization of the surgery, and also at follow-up sometimes. And then maybe see even statistical associations, and we have a statistical nerd here, evaluate associations between surgical approaches and the early rhythm outcomes. And again, and then there's the importance of this. The hypothesis is that increased and more consistent use of guideline-supported surgical ablation may reduce future atrial arrhythmia burden, decrease the long-term anticoagulation, improve overall outcomes, length of stay, blah, 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 blah. So that's kind of like what I wanted to say, because I know that Sophie, for example, who's also a student, is going to join us, and I wanted her to, to listen to this recording. Now I'm going to shut up, and I'm opening it to everybody.
Thank you, Dr. Lav. I think it's a very interesting project, and since the time you talked about it, I read the guidelines, and it's very interesting, how the trend is going now to do more and more surgical AFib ablation. One question I would have is, so we want to see post-op AFib, and we know that a lot of these patients, even if they have ablation, they will have some AFib. So do we want to see the patients discharge, what the rhythm they're in? Do we want to follow them longer? In that case, would we have to select patients from prior years and not recent years so we can have more follow-up data?
I think that is a great question. I would say there's always a trade-off if you go too far back, because just the Jefferson Center City has changed so much. So many surgeons that were here 5 years ago are no longer here, and users. So I think that the more, I'm not saying to do it like starting from today, but I'm thinking maybe throughout 2024 would be effective.
Okay.
That's just a thought, or 2000. I'm open to your ideas. 2024 in the first year of 2025 until July, just as an example, maybe 18 months.
Okay, and then
but the goal is, you need to understand that the goal is, if you do the ablation correctly, the success should be pretty good, and there's a good chance that you're not going to see atrial fibrillation in the index hospitalization, meaning you won't see any. And the worst is that those patients that I see frequently, and Bayes see frequently, that they have quote an ablation, but it's a surgical something that is so, and that in 24 hours they're going to be back in the atrial arrhythmia, and usually they are, even on amiodarone. So my answer to this is that, yes, we need to think about how to follow up, how to assess the follow-up, if there's halters, if to go. I think that it's not going to be so many patients, because it's only those with who had heart surgery and AFib before that. So I think if we have enough people, we can do manual review of the chart and see if they had, you can use keywords, AFib, you can look at the notes of the fellow, whatever, and see if they're. if there was not, if there was an ablation or not, it's easy to find out on the operative note. So that's, I hope I answered your question. And again, it's
Yes.
open. This is the beginning. So if you want to do something like 2019, I see the benefit because there's 5 years follow-up, but maybe it's out of the scope for this project.
Okay. Yeah, makes sense.
I had I guess a question and a comment. So, it's unclear to me what the purpose of the following up to see if they had AFib recurrence is, if we're calling this a QI project, because like I feel like whether or not the box lesion set is effective for treating AFib with surgical ablation, then that's better established by the RCTs that they've done on this before. And if we want to evaluate like the efficacy there, then that might be better served by like a meta-analysis of surgical ablation. But
I'll tell you, it's a great question, and I hear what you're saying, that we're not trying to, but let me answer that, because based on what I hear, including conversations with leading surgeons, and I participated as a panel in a big conference with Dr. Bara, I forget his name, but he's like the guru of the heart surgeons on atrial fibrillation. The standard of care is like the gold standard is to do a box, for example, and not just the lines.
Yeah.
So it's not that we're really testing, it's not like an RCT to show if it's superior or not. But what it is for is, let's say that we come back and just say that we present this data we arrange a grand rounds. Yes.
Fire engines are here. You gotta go. They're coming in the building to evacuate us.
There's fire in the building?
I don't know, but it went us out.
Okay. I'm gonna come out in a second. Listen, guys, you can continue this conversation. Please do. Oh, you know what? But I can't because I have to, they're literally kicking me. There's apparently a fire in the building, so I have to go. But I'll tell you that, just to answer the question, hopefully I'm not gonna die from the fire, is that,
I'm close to you. If you come in this entrance, like then you can just join on my phone.
where are you?
Do you know like where 1840 is, where you do morning report?
Yeah.
Yeah, I'm like right by there.
Okay, I'll run to you, but then, so I won't stop the recording yet. But the point is that I'm making to your question is that I think if we do an education session, let's say, a grand rounds with CT surgery or whatever education, and we show them that a vast amount of patients that had an indication for the ablation didn't get it, and B, the approach that they used is just not the standard of care for the majority of the surgeries. And anecdotally, we'll show them that indeed many of them had recurrence of atrial fibrillation.
Mm-hmm.
So I think that would be very powerful motivator. And I've been doing these projects, QI projects, and it will change practice for sure.
Yeah.
I'm going to keep this computer recording to continue recording. I'll run over to you. Wait for me by the door on Chestnut.
Yeah, I'm right by that door.
And Jack, to get the patients, that should be relatively straightforward.
Yeah. Oh, very easy. I can pull it on Slicer Dicer, no problem. Send it over to Dr. Lev, and then he can get us an Excel sheet of all the names.
Okay, awesome.
Yeah, but what was I gonna say? Yeah, the basically what I like, I guess Dr. Lev would like it just for like anecdotal presentation, but of it, but really like, I guess we're sort of working under the assumption that the box lesion set works and is the most efficacious. And so then really all we need to do is just see, are we doing the box lesion set, and are we doing it in everyone that should get it? And then if not, we need to be doing more of it, because like, let's say, what if we find anecdotally on ours, that just a couple of lines just so happens to show efficacy, and then the people who did a small handful of box lesion sets was not efficacious, just because we're probably working with small numbers. Because I mean, I've only been here a year, and like we've only been here a year and a half. I don't think I've seen a single surgical AFib ablation. So if we're working really small numbers and just by chance, you know, it works out, it just seems like extra effort for not a lot of payoff. I mean,
Mhm.
see if he's here. No, I don't see him yet. So yeah, that's
I
all
see.
I'm thinking, you know, because like there's going to be what, like 5 or 6 of us going through charts. It's not
Yeah.
an insignificant amount of time to go through and like look to see in the op note what happened, what was a pre-op diagnosis, what was a post-op diagnosis, especially when like it's all like it's never coded correctly, you know, and it's just the way it is with like doing these sorts of things. But you know, to then have to add on like Holter monitor follow up and stuff, I just don't know if I see um a benefit.
A benefit to it. I see what you
Yeah.
mean. I mean, I think we can also determine that after we see the estimated number of patients who are eligible to be included in the QI. So, like,
Yeah.
depending on the number, then we can see, like, because like Dr. Lev was saying, like using the keywords, just like typing AFib in that patient's chart, you'd
Yeah.
see if like they had previous AFib, and let's see like if they had a ablation, surgical ablation, to see if they have any recurrence of AFib.
Yeah.
I mean, that doesn't mean they didn't have AFib, maybe they didn't catch it yet, but
Yeah.
so maybe we can start by looking at what numbers we're looking at to see how much
Yeah.
time that will.
The other
Another
thing
th
is, oh, sorry,
Yeah.
go ahead.
No, go ahead.
We just need to know which oh, is that, oh no, sorry, I'm gonna look out for
Dr. Lev.
time. Yeah, I don't know which way he's coming from, but which hospitals do we want to include? You know, because I know Dr. Bavaria at least operates at Lehigh Valley a
Mhm.
decent amount, I think. I could be wrong there, but you know, our slicer dicer, our Epic, does not connect to their Epic. Oh, here it is.
Okay.
Wait, her
So
name
then,
is, I forget her name. It is,
But
Ruben. Yes.
so then
yes.
it would be our institution then, if we
Yeah.
don't have easily access to the
Yeah, we
to
have
the.
easy access to like 7
Yeah.
Jefferson hospitals, but not all of
Okay.
them do CT surgery. Like
Yeah.
one of them's Methodist, you
Okay.
know,
No.
Okay.
and they don't do any CT surgery.
Okay. I think the
There's-
main site is gonna be our site.
Yeah.
Um,
So,
Another thing I
um,
was thinking about, if we should think about like collecting any safety parameters, because like if we're saying
I know, I'm
it's a
out.
QI project, we should
All
do
right, bye.
more ablation. Should we
Yeah.
collect any safety
Okay.
parameters on these patients who underwent ablation or not? Like any complications of the surgery, did it increase time of surgery, etc. Right? If we're thinking only positive, we should also think what's the downside of it.
Mhm. Just to catch you up, we were talking about if there was any benefit about collecting like AFib follow-up. If we're like, what if you incidentally find that the lines on our small number of people just so happen to be better than the box lesion set? And then which hospitals do we do? Because we only have easy access to about
I think
7
Center City.
hospitals. Okay, just Center City.
I think that this is a local urine medicine.
Mhm.
I work here, I direct the floor. Amin works at TJUH. Pavri is interested in TJUH, Frisch is, so I think it could be, but this is the flagship. And I think that based on what we see, it could be applicable and relevant to all of the Jefferson hospitals.
Yeah.
But listen, I know that the results it's a QI project, but I know what the results are gonna be. They're not gonna be good. We're not adhering to the guidelines as we should. We're not doing enough, and we're not doing enough approach. I know this because I met, like we had me and Frisch, who's the director of EP, and Chin, who's one of the surgeons. We had a meeting and we kind of like went over and we know that we have a serious problem. I mean, that's why Pavri called me. He's like, yeah, we have a problem here. We're not doing enough. And those that we do, often they just do the lines and it's not effective. Like almost all of them have recurrence. And I mean, then we can think about like how it can change practice. Like is that we can do grand rounds after this. We can have education sessions. We can talk and communicate these results with everybody from all of our colleagues with CT surgery. But the reason that it's important to medicine and cardiology is that it's the same. I mean, that I'm interested in, like, I had a project that I was involved with, which is looking at arterial grafts in CABG, because if you use a lima and veins, it's not the greatest option.
Yeah.
And we use too many veins here.
Yeah.
So why is this relevant? It's not only relevant to CT surgery, it's relevant. We are the cardiologist. Ultimately, you're the cardiologist. You make the decision who you're going to refer. If you have a patient with atrial fibrillation and you know that you're going to send, and a surgeon is not going to do what is the guidelines suggest,
Yeah,
then maybe you're going to refer them elsewhere. Meaning, I'm saying it's the responsibility of all. It's the ultimate responsibility of the cardiologist. The cardiologist should be saying, "You're going to surgery. I want a bio AVR, fine, left atrial appendage closure, and a true ablation." Like, the cardiology community should be involved in this decision making.
yeah, makes sense.
We were talking also if there's any benefit to collecting safety data on these patients, like to see if the surgical ablation affected the surgical time or any complications, etc., or just look at Afib per se.
I mean, I know that we can involve in the discussion, and we can talk to Cecilia, for example, but she said that usually if you do it correctly and you have some experience, it adds like 10 minutes. Max.
So like could the study like generally look for the efficacy of it when it's done by an EP, like, and then you contrast that with when it's done by a state surgeon? Or is it more just to look and make sure that they are even like trying it?
That's a good question. I think that it's so, I don't think that we can compare the outcomes directly between the EP ablation and surgery, because the context is completely different. CT surgery, you're exposing the heart, the risk of future procedures. It's more of a, often it's more of a, so I think it would be beyond the, like, when I think about a good QI project, it should be simple. I think that if we start comparing it to EP ablations, you add confounding factors and a lot of complexity.
Okay.
It would be good to know if but that's like RCTs to compare surgical ablations to EP ablations. I think that it's beyond the scope of this project. I don't know what you think.
Yeah.
Yeah, makes sense.
So I think that the next step, if this is something that sounds like everybody here are interested in this, and the good thing is that we do have the support. I mean, to get technically the details, easy. We can get through CT surgery, my colleagues can get the list of all those people who had surgery, and then we can play with the exclusion criteria. We probably should do an IRB for this because it's patient information.
I don't know if we need an IRB for QI.
If we want to publish it.
If we want to publish it, yeah.
And I think we should publish it because it's the issue is that this is not like a small, this is everywhere. I mean, except maybe very specific places that they have a surgeon that loves to do it. Most of the places are not adhering to the guidelines of doing it and doing it correctly. I think, if you want to do an IRB, I think I'm very close with, what's her name? So close that I can't remember her name. Jen. She's from the JCR. Not Pam, the other one. I'm blanking on her name, but we can, if we have a way to submit it fairly quickly, because it shouldn't be very complicated.
Okay,
This is just a preliminary meeting, so we don't have to go into the methods and everything, but that sounds reasonable. I mean, and everybody.
It does. It does for sure. I can start collecting, building an Excel sheet with what are the variables we need to collect, just so we can, and then share it with everyone, just so we can have ideas of what the number of data we need to collect.
Good, I like it.
Cool.
All right, I'll send the recording to everybody.
Sounds good.
Thank
Thank
you.
you, everybody. I'm gonna go back to my fire zone.
Thank you so much.
I guess we'll get all the names from Dr. Lev.
Yes.
But I'll pull, like, it's very easy to do the slicer dicer real quick.
Yeah.
So I'll pull that and just share that in an Epic chat
Yeah.
with everyone. Because that way we can also like filter ahead of time by like AFib or not.
Mhm.
And yeah, Max,
You're
you
gonna-
have an Epic account?
Yeah. Yeah,
Okay.
I do. So like I just need to get like they won't let me like have it at home though, so I actually have to go in, but it's not that far. So yeah, no, I could go on.
Okay.
I don't think it should be a problem.
Cool.
All right, and Jack, you're gonna exclude permanent AFib or just include all AFib who had surgery?
I will so I will try to exclude permanent AFib, but you know, it all depends if they like coded it right in the problem list, you know.
Mhm.
I feel like usually
Yeah.
it's just written as AFib. So if
Yes.
it's coded as permanent, I'll take it out. Yeah.
All right. Sounds good, man. Thank you so much.
Yeah, of course. All right.
Thank
Sounds
you.
like that's it.
Thank you, guys.
All right. Bye, guys.
There you go. Have a good one, y'all.